important. So we are just going for a simplified approach. So I've got this young 6-year-old girl, and the mom is worried that the child is short. Most important, again, from morning we've been listening to Srinivasan sir and in the other hall to other speakers about how important a clinical history and examination is going to be. So this mother did not have pregnancy-induced hypertension. She did not have gestational diabetes, neither did she have oligohydramnios. Remember, your intrauterine environment is going to determine how you are. So if I can use Tamil, and if Dr. Any of them who can't understand Tamil, ஒரு செடி நல்லா வளரணும்னா அந்த மண்ணு நல்லா இருக்கணும், தண்ணி நல்லா இருக்கணும், வெயில் நல்லா இருக்கணும், அந்த மண்ணோட அதுல இருக்கிற சத்து நல்லா இருக்கணும், அந்த விதையோட வீரியம் நல்லா இருக்கணும். அப்போ for a child to grow, the environment in which the child grows, how the family is, how tall are the parents, what was the nutrition the mother got, what was the nutrition the child got, including breastfeeding, did the child have any other illness, and ultimately after all of these is seen, only then will growth hormone deficiency have to be determined. So please remember, investigations are the least important. Your clinical history will score over anything else in the evaluation. Next, neonatal period. This is a term appropriate for gestational age. In small for gestational age infants, remember, at least 30% may be short, but at another 20% will catch up and 10% can be pathologically short. So the weight and the length of the child at birth is going to be extremely important. The birth weight of this child was 3 kgs. Unfortunately, nobody had measured the length. That's okay. 3 kg means probably this child was well at birth. This child never had significant past illness. Again, from this only history, you can say whether this child had any reason to be short. This child did not have chronic respiratory illness, did not have a chronic renal illness, did not have a chronic cardiac illness, was never on any long-term medications like steroids or any other illness. So these all rule out the environment. These parents were fine. They were not separated. She did not lose any loved one in the recent past. I had a recent short stature where the child came from an orphanage. The mother had committed suicide. The dad had run away. The stepfather had sexually abused this child. This child came from such a severe socially deprived society. The short stature was because of the psychosocial deprivation. Before you correct that, you cannot think of treating any other condition in this child. So the dad is 173 centimeters. He shaved at 16 and a half years. Though all of us know the importance of development of testis as the first sign of puberty, a testicular volume of more than 4 ml indicates the onset of puberty, but nobody would remember that. But he will at least remember when he shaved for the first time. That's almost nearing the end of puberty, but it will give you an indication. The father will say, I went to college, only in second year I shaved for the first time. When I was in final year of school, I always felt inferior to my classmates. Everybody was taller than me and I felt very bad. But then ultimately I grew up and became taller than my siblings. So that is constitutional delay in growth and puberty in the family. Again, you can also ask, when did father's sister attain menarche? That's as important as knowing the dad's puberty. The mom, she was 160 centimeters and she attained menarche at 12 and a half years. So that's quite easy to evaluate. The mid-parental height. So this genetics play an important role in the growth of the child. So the mom is 160, the dad is 173. And then I think all of us know about the mid-parental height evaluation and then the clinical examination, which is absolutely fine. So we now go on to the next slide. So I think this formula, I think there's no need to explain to this august audience. So this, I think, is the most important part of the whole lecture or evaluation of short stature. A growth chart absolutely scores and is the most important part of evaluation of a child, whether it be short stature or well-being of the child, everything depends on this. Again, a longitudinal evaluation. This child, once this child comes to you as a newborn and starts, pediatricians, I think, are a part of the family for most families, which includes my own pediatrician is Dr. Angeline Prema. I think till today, Dr. Srimati and Dr. Angeline Prema follow up my children, though they are both adults. So you grow up with the family, you follow them up. Not only emotionally, I think you also need to remember that you have to take a height periodically so that these children are monitored on a growth chart. 2 height measurements, at least a minimum of 6 months apart, will give you a very, very good clue on where you are going and how you're going to evaluate this child. So we will go on to the next part. So I put those height calculations. So this is I've divided that. I got 160 centimeters, which I've marked on the 18th year, which is the adult height potential. That is the predicted adult height of this child. So you mark the 160 centimeters on that, put 6 centimeters on either side, which will give you the mid-parental height range along which the child has to grow. And now you follow up this child, you're seeing this child grow right along the same centiles all along. So this child's growth is appropriate. This is all that you need to do for evaluation of the growth of the child. You don't need anything more than a growth chart to evaluate. So this is a normal growth. How would you take a height? I think that's the most important next point that I would really like to stress for this audience. You could have an Harpenden stadiometer, or you could just have something on your wall, which is always the same. Don't keep changing your scale. Stick the same scale. The child is going to follow up with only you all along. But the only thing I would say is keep a board on top of the head. Don't keep a pencil, a pen, and then that goes angulated like that. If you don't like the family, if you like the family, it may go like that. So it's important to keep a board, or even the same board in the same stadiometer. It could just be a wall stuck scale. That's fine. But keep the same one to look at the longitudinal growth, which is extremely important. So this is how you would measure. The child's feet are together, flat on the board. The child's back of the knees touches the wall, touches the stadiometer. The bum touches it. The shoulders touch. For a child, the back of the head can touch the stadiometer. For an adult, you have to maintain the Frankfurt plane. So what is a Frankfurt plane? You draw a longitudinal line which runs just above the tragus and along the inferior margin of the orbital, and this is the Frankfurt plane, and this has to be parallel to the floor. So this is how you would take height for the parents, because you're going to look at the mid-parental height centile. So it's as important as the child's measurement. So both the mom and dad have to be measured accurately, exactly as the same way as the child. For the child, they do not have too much of tissue on that back, so they can touch the wall, and the head can also touch. But whereas for a parent, the head may be a little bit in front, but if you maintain the Frankfurt plane at a parallel to the floor, then your height measurement is fine. So what are the factors that are going to predict the adult height? Mid-parental height centiles, bone age is an extremely important clue. I'm not sure, I thought everybody knows a left hand X-ray is enough. The wrist alone is not enough. I think any number of lectures have been given by Hemchand, Dr. Vaman and his team repeatedly on how to measure bone age. But in spite of that, I continue to get referrals with 5 carpal bones, 6 carpal bones. Those are not important. You have to look at the whole hand. And I know that Tanner Whitehouse chart is what Hemchand used. I'm much more familiar with Grulich pile charts. The terminal phalanges and the growth plate, plays a much more important role than the proximal bones. So you have to take an X-ray of the whole of your left hand up to the tip of the fingers, including the wrist, the left hand, but it can be a non-dominant hand in a person who is left-handed. So it is always only one hand X-ray, and it is compared to a normative data that has been published. And the Grulich pile charts was formulated several years ago, but then that is what I'm comfortable with. But I know that Hemchand and his team are much more familiar and comfortable with Tanner Whitehouse charts. So what are the classification of short stature? All of us have already thought about familial short stature and constitutional delay in growth and puberty. So familial, appa avara potta avaradha molekkum, tovara potta tovaradha molekkum. So you have to remember the vedayoda virium determines the growth of the plant. So how tall the parents are is going to influence the height. There's no point in trying to push them and pull them apart to make them tall. Make them more comfortable with who they are and how they are. You tell this is what your height potential is. Unless absolutely necessary, you don't have to go for medications. Pathological will be, I think that's something which all of us know, less than -2 standard deviations for age and sex. All that you need to do is do a growth chart. The child was growing along the same centiles and suddenly starts dropping off. Did not grow. That means the environment was not good. The child was not supported in a supportive environment, or there are pathological causes coming into play. It could be hypothyroidism. It could be chronic steroid usage. It could be growth hormone deficiency. It could be Cushing's. Any reason, but there is some reason which has made this child's chart go flat. So again, I come back to my most important point, complete history. From the time the mother was, you should remember the mother's health plays an extremely important role in the well-being of the child. and then how the child was born. I mean, all through your antenatal period, then the birth of the child, then the growth of the child, then the follow-up, and then you will evaluate short stature. You're not going to look at one point in short stature and tell this child is short. That doesn't work that way at all. Physical examination, accurate height and weight longitudinally, mid-parental height, and then a bone age. So I think, again, all of these points, all of us would know. Hypoglycemia, micropenis in the newborn period, nystagmus, that is a very important finding which can help you diagnose SX1 mutation, low energy level, short children, cherubic facial features, reduced lean mass and muscle, increased fat, central abdominal fat, and then reduced hair growth and frontal recession. This is a growth chart. I mean, data I got from the American Academy of Family Physicians. You can actually, I would go with what Dr. MR always teaches us. The child is 50 centimeters at birth, which is the most important part of a growth in all human beings. The intrauterine period is the period where you grow maximally. So that's 50 centimeters for the first year. The next important period of growth is half of that, 25 centimeters. The second year, half of that, 12.5 centimeters. The next year, it's 6.25 centimeters. And then you go at 4 to 5 centimeters or up to 5.5 centimeters a year. That's so much easier to remember and to monitor the growth of these children. So these are height velocity charts. I find this very, very useful. A longitudinal growth velocity, if a child has grown 3 centimeters at the age of 4, and that I mark it here, this height centiles is far, far below. So this is the 3rd centile, 10th, 25th, 50, 75, 97, not like your growth charts. Here, the 25th centile is the most important one. Any height velocity charts will show a height growth velocity of less than 25 centile. That child, actually in New Zealand where I trained, you qualify for a government-sponsored growth hormone if your height velocity drops to less than 25th centile. You're not dependent on your growth hormone stimulation test. You're dependent on the growth that is recorded. So that is why I told sir, it is not important to have investigations. It's important to look at the child and see how the child grows. So next one, this is the height velocity chart, which Dr. Varman has published recently. This actually, if you look at it, it is a little bit attenuated compared to the Western population. The next one is the sitting length compared to the leg length. This is not commonly practiced here. We use the upper segment, lower segment ratio. It's a bit tedious to measure the upper segment, lower segment. It's much more easier to measure a sitting length to leg length. This also has important relationship to your systolic blood pressure, development of obesity, and later metabolic diseases too. So I think this is some body proportions which all of us know. I will just go across with some clinical pictures. So this is one of my growth hormone deficiency, central adiposity, missed till 17 years of age. This is a subtle sign of central hypothyroidism. This is micropenis. This is a central adiposity, cherubic facies, and this was 2 children with growth hormone deficiency. So how would you investigate? First, investigate for chronic illnesses after your history and clinical examination, bone age. Any girl who's short warrants or demands a karyotyping. In Turner syndrome, the only feature which stands across all girls with Turner syndrome is short stature. A short neck or a web neck is seen in only 37% of patients. A short 4th metacarpal is seen in only 47%. A cubitus valgus is seen in only 50%. So remember, all clinical features need not be present in Turner syndrome. Any girl who is short has to have a karyotyping in a decent lab, because you could miss Turner syndrome if it is not done in a proper lab. So this is a very, very good growth chart. I think if any of you are able to access Pediatric Clinics of North America, published in 1983, which was a pre-investigation era, you would get a very, very beautiful growth chart, a flow chart on how to approach evaluation of short stature. If you have pathological short stature, do they have dysmorphic features? Don't they have it? If they don't have, then you think of chronic illnesses, rule out all the chronic illnesses, and then think of endocrine issues. If you have dysmorphic features, look at whether if they are disproportionate or proportionate. Disproportionate can be short trunk dwarfism or short limb dwarfism or rickets, whereas proportionate could be in Turner syndrome. It could still be disproportionate if you have a SHOX gene mutation, trisomy, Russell-Silver, Noonan, Prader-Willi, DiGeorge, and fetal alcohol syndrome. So this is a girl who's just growing and suddenly starts shooting up. What does this indicate? The growth, spurt in growth is the first indication of onset of puberty in a girl. Even before you start seeing a breast development, you will see the start and growth spurt. So this is a much more important clue rather than looking at breast development. This will give you a warning saying this child is going to go into precocious puberty, help you intervene early. So growth charts are extremely important. So what is the sequence of puberty in girls? That's why I said it's the start of the growth spurt, which actually antedates your thelarchy. Then comes your rapid growth spurt, puberty, and so on. Whereas in a boy, the growth spurt actually happens at the end of puberty. So this is a family with the mid-parental height right short, less than the third centile. This child is growing along the family potential. So this child has familial short stature. This child actually was okay till 3 years of age, started dropping off on its centile subtly, but then we usually, some of us do investigate to see we are not missing a growth hormone deficiency, but continued to grow along the third centile, started puberty a little bit late, caught up for the family height potential. This is very, very characteristic of constitutional delay in growth and puberty. This is my third slide. This is another growth chart. You see the child, the mid-parental height centile. The family is quite tall. They are at the 75th centile. This child was growing okay, but then started dropping off. So this indicates an onset of an insult. It could be psychological, it could be chronic illness, or it could be a hormonal imbalance. This child started dropping off here, and then we evaluated initiation of growth hormone in a growth hormone deficiency. This child caught up and went to the family height potential. So this, I think, is just a summary of all that we saw so far. Turner syndrome charts, they have an attenuation. I'll just finish up this. This is an attenuation of their height potential at puberty, which they don't have. But I don't use Turner syndrome charts. I try to catch up my girls into the normal for the, I would say, the society, rather than looking at specific growth charts. We do have Noonan syndrome charts. So this is a child with type 1 diabetes, badly compliant. Look at the hepatomegaly. He's dropping off on both his weight and height. This is a Mauriac syndrome. This child is short, has gone into puberty. Remember, when you have early puberty, you will be taller than the children of your age. But this girl is short and has gone into menarche. So this is hypothyroidism, or rather Van Wyk-Grumbach syndrome, where it was a pseudo-precocious puberty. So this is a chronic illness. So manage the underlying illness. In multiple pituitary hormone deficiency, you have to manage hydrocortisone first. If you give thyroid hormone before hydrocortisone, the patient could crash. Hydrocortisone first, then thyroid, and then growth hormone. You cannot check for growth hormone deficiency without being in a euthyroid state. And Turner syndrome, I think I would just leave all of that. And I think growth hormone, only point for growth hormone I would make is don't depend on a one single baseline value of growth hormone at any point. A patient who's growing, first growth chart, then you will look at your thyroid status. If they are euthyroid, then you will do a sex steroid priming, and then do a growth hormone stimulation test. It is important to do at least 2 stimulation tests. You are trying to prove that the patient is growth hormone sufficient, and you're not trying to say this is insufficient. If they fail the test, then they qualify for growth hormone based on the growth percentile and not on their tests. I will leave it there. Thank you very much.
Thank you, ma'am, for a short and concise presentation and breaking down the problem of approach to short stature. Thank you. May I request Namchiwam sir to present the memento to. If there are any questions, please. Yeah, just a second.
Thank you, both speakers. And just a comment to constipation and what MS is from Chennai. One of the important reasons for persistent constipation is the parent misconception about giving laxatives for adequate amount of time. They always think that when a child is addicted to medicines, they stop prematurely. So one thing when it comes to the parents, we have to tell them very clearly that your child will need medicines at least, for example, the child had consumption of 1 month, you can tell them at least the child needs twice the amount of duration the child had consumption, 2 or 3 months. If you tell them right at the start, starting the treatment, that helps both the family and the child. Thank you.
Thank you, sir. Madam, the short stature problem, very pediatricians, only problem is, if you identify, just to pass on the problem to the madam. She will tackle the whole problem. Because in busy pediatric practice, sometimes it may be very difficult. The continuous growth chart எடுக்கிறது compare பண்றது hormonal அதெல்லாம் it may be very difficult for pediatric practitioners. பார்ப்போம் முன்னாடி நம்ம லெவலுக்கு முடியலன்னா initial stage itself you must refer the child to the endocrinologist. That is the best solution, I think.
இல்ல சார், நீங்க அங்க இருக்க செக்ரட்டரிக்கு ஹைட் எடுக்க சொல்லி அவங்களே அந்த புள்ளி வைக்க சொல்லிருங்க சார். நீங்க உள்ளார வந்தா புள்ளி கரெக்டா இருக்கான்னு பார்த்தா போதும்.
ஐடென்டிஃபை பண்ணி பண்றது ஈஸி. அதுக்கப்புறம் ட்ரீட்மெண்ட் பார்ட் ஆஃப் இட் ஐ திங்க் யூ வில் ஹேவ் டு ரெஃபர் டு endocrinologist. ஏன்னா ப்ரொலாங்டு ட்ரீட்மெண்ட் கண்டினியூஸ் ஃபாலோ அப் மே பி நெசசரி. ஹார்மோனல் தெரப்பி அதெல்லாம் கொடுக்கறதுனா காஸ்ட்லியா இருக்கும். பேசாம அவங்க மட்டும் தள்ளி விட்டா அவங்க பார்த்துக்க போறாங்க.
I think something for everybody to be happy about. Everybody in India is jealous of Tamil Nadu and Kerala. Nowhere in India do you get free growth hormone. I'm really pleased about what's happening with all our government hospitals, including Taluk Headquarters Hospital. It is offered free to patients. And yes, and I really admire all our pediatricians. I've never seen one single pediatrician say no to a deserving patient. And everybody, Vaman always says, it looks as if you're living in England, not in Tamil Nadu, not in India, because you get such fantastic care in Tamil Nadu. And I'm really thankful to all the pediatricians for the care they deliver to our patients. Thank you.
Ma'am, just one more doubt, ma'am. Availability of growth hormone in our country settings, ma'am.
Yeah.
Depending upon the socio-economic status, it's a costly treatment, no, ma'am.
முதல்வர் காப்பீடு திட்டத்துல, I have never prescribed growth hormone for an undeserving patient. In Coimbatore, Erode, Salem, Gopichettipalayam, Karur, பொள்ளாச்சி, மேட்டுப்பாளையம் எல்லா ஜிஹெச்லயும் என்னோட பேஷண்ட்டுக்கு ஃப்ரீயா growth hormone கிடைக்குது.
So தமிழ்நாடு காப்பீட்டு திட்டத்துல
தமிழ்நாட்டுல பிரச்சனையே கிடையாது. இதுல வந்து RBSK ஃபண்டிங்ல some states get, like Kerala gets only for growth hormone deficiency. Maharashtraல corporation hospitals-ல கிடைக்குது, but not for all indications. தமிழ்நாட்டுல our doctors are very good. They actually, and the government is also very helpful that way.
Okay, thank you.
Thank you.
So
thank you, ma'am.
thank you. So may I request Namachivayam sir to present the memento to Somasundaram sir.